Hello, my name is Dr. Michael Priddy, and welcome to the video lecture on cognitive behavioral treatment of insomnia. The World Health Organization defines insomnia as a problem initiating and/or maintaining sleep, or the complaint of non-restorative sleep that occurs on at least 3 nights a week and is associated with daytime distress, impairment, or difficulty functioning. In this video lecture, we will focus on a comprehensive 6 to 8 week cognitive behavioral approach to treating insomnia. In the past, insomnia was often thought of as basically a symptom and not as an actual disorder. Say a patient had back pain, and because of their back pain, they had difficulty sleeping. But that's not the case. The focus of this lecture is on the type of insomnia referred to as primary insomnia by the American Psychiatric Association. That is to say that this type of insomnia is a particular entity in and of itself, and not the result of some underlying medical or psychological condition. This type of insomnia is somehow learned or maintained through a sort of negative conditioning to the bedroom. You see, a person suffers from insomnia on a regular basis, such as, shall we say, 3 or 4 times a week, he or she begins associating the bedroom with an inability to sleep as opposed to a place where one can actually sleep and rest, thus increasing the patient's tension and anxiety the closer they get to their bedtime. Being that this type of insomnia has a learned component to it, it is appropriate to apply a cognitive behavioral approach as a form of treatment. Many research studies have confirmed this. Initial intake. When a client presents with a complaint of chronic insomnia, such as having insomnia 3 to 4 times a week, it is prudent and necessary to take a thorough patient history. We break this history down into 9 different categories. First, patient identification. We begin by getting the patient's identification, their name, address, and contact number. Second, vital statistics. We then record their vital statistics, their age, their sex, their height, and their weight. Number 3, the chief complaint. We ask the client to describe in their own words what their chief complaint is, such as, "I can't sleep at night," or "I keep waking up and I can't fall back to sleep," etc. Number 4, a history of present illness. The history of present illness is to establish how long the patient believes he or she has suffered from this type of insomnia. 5, the past history. We also want to find out if the patient has a past history of bouts of insomnia. And 6, we want to find out if there is a family history of insomnia, such as, did one or both parents have bouts of insomnia? Did grandparents have insomnia? Do siblings have insomnia? Number 7, a social history. The social history is important because it tells us something of the patient's lifestyle and how that lifestyle can be contributing to their chief complaint. For instance, do they use alcohol? How much alcohol do they use? When do they normally go to sleep? What time do they get up? On the weekdays versus the weekends? Do they nap? Now we want to find out about their list of medications. We need to get a list of medications the patient is taking because these can often cause sleep disturbance. For example, certain antidepressant medications depress REM or rapid eye movement sleep. This can cause more fragmented sleep and less dreaming. And finally, number 9, we want to make a preliminary diagnosis. We make a preliminary diagnosis using the International Classification of Sleep Disorders, the 2nd edition, Diagnostic and Coding Manual. This is a sort of a DSM-4 of sleep disorders. Our next step is to begin a behavioral approach to monitoring the patient's sleep patterns using the sleep diary, as you can see on the slide. As you look at the chart, you can see that we break it down into completing a chart in the morning and completing a chart at bedtime for each day of the week, 7 days a week, all the time while the patient is in treatment. When they complete it in the morning, they want to talk about what time they thought they went to bed the night before, what time they got up this morning, give an estimate of how long they thought it took them to fall asleep, and again have an estimate of how many times they remember waking up in the middle of the night and how long they thought they were awake, a total time. Also, they want to estimate how much sleep they obtained that night. Now at bedtime, they want to record naps, the number of naps, the time of the naps, and how long the naps were. Also, did they drink any alcoholic beverages? Again, the number of them and the time that they drank the beverages. At the bottom of that, you can see listing the stresses of the day. Did they have an argument with their spouse? Did they have a breakdown with their car, such as a flat tire or a dead battery? Next, we want to rate how they felt today. Were they very tired, very sleepy? Or were they feeling wide awake, or somewhere in between? Next, we want to find out their irritability level. Irritability is a symptom of insomnia. Was there no irritability felt, or was their irritability level very high? And finally, again, we want to find out if they were taking any kind of medications, not just prescription, but also over-the-counter medications as well.